do now that I'm here in the practice. So probably the most common question is going to be, why do these things fail? Well, infection, you guys have probably seen some of those. Those are probably the devastating ones. Aseptic loosening, that's actually, in the most recent literature, probably the most common reported reason to revise a total joint. Instability, this is one that takes a lot of really talking to the patient and trying to figure out if it's a knee or a hip. It's pretty easy. If they come out, that's instability. So these patients are oftentimes in and out of the emergency room. And depending on what their dislocations come from. So if they're acute after surgery, usually the first time they get to go back to rehab, go back to their posterior hip precautions, try and get their muscles get strengthened up, and oftentimes they'll scar in and not need anything else. If they're 10, 20 years down the road, a lot of times it's due to wear and tear on the plastic, and that leads to a larger socket now that the ball's not sitting in as well, and will lead to dislocation. So those, oftentimes, we won't let them go through a second time. We know what the problem is, we try and identify it and get it taken care of. Osteolysis, much less common now that we have the third generation of cross-linked polyethylene, much fewer plastic particles, much less bone response, causing resorption of the bone. Periprosthetic fractures, and then stiffness or arthroplasmosis. Types of revisions, you've probably seen the whole gamut of it, from patella revisions or even a polyethylene exchange, or pretty simple surgery. They recover pretty quick, sometimes even faster than a total knee. That's because it's minimal soft tissue surgery, minimal bony surgery, and basically we're kind of trying to restore the ligaments out to where they should be for them. Oftentimes they're either further down the road and they just need a bigger piece of plastic put back in, or maybe they're a year or two down the road and they've loosened up, or they just weren't tight enough to start off with. Full revision, we take everything out, put new stuff in, and those probably take a little bit longer to come back from because it's more bony work. And then the two-stage revision, and this is the gold standard for infection in the United States. Hip revisions, polyethylene exchanges, oftentimes for instability, that asymmetric polyethylene where we talked about. Femoral revision, sometimes the femur comes loose, and that's all we need to revise. If the socket's nice and stable, we leave that in there. Acetabular revisions, sometimes the position of the cup isn't right. That might be the reason why they're dislocating, and we might just do that. Or we take everything out and start all over again. Extended trochanteric osteotomies. Those are the ones where you're going to see where they come back, and I've actually given them some restrictions as far as they can't abduct their hip. Maybe some weight-bearing restrictions based on how the osteotomy goes. This is, what you'll see is the cables in there, a little bit low, probably a much longer incision, and they're going to be quite a bit more painful. The reason we do the osteotomy is because the implants are going to be well fixed up in this area, and sometimes even further down, depending on what the implant type is, and if they have an infection, and we have to get that out of there, or they have signs of loosening. Even if they have signs of loosening, that doesn't mean the implant's just going to fall right out of the wound. So there's spots where there's spot welding, but there's other areas where the implant is loose enough that it's causing pain for the patient. So occasionally we'll have to do one of those. What makes a revision different? The amount of bone loss. This might come during implant removal. It could be from that osteolysis, from the bone resorption, from the particles that develop from the polyethylene wear. Infection debridement. Debridement is actually the most important treatment for the infection, almost even more important than the antibiotics themselves. So you debride everything that looks bad, and you build up from there once you're done. Stability. The soft tissues might not be that adequate. I've had a couple hinges that we've done because they don't have collateral ligaments, and so those patients are going to be unstable if they don't have something else from the implant. You can see the little bars in the middle here. These are implants that aren't hinged, but they have a thicker post, so they might have less motion, or occasionally that post is thick and it's also taller, so they might have some patella impingement. Sometimes their motion is going to be limited by that. Sometimes they'll be more stretched out on the inside of their knee versus the outside, or more medially than laterally. And so because of that, they'll need a little extra support. Sometimes we'll reconstruct those ligaments if we need to. So infections. There are certain criteria that I look at for infections when patients come in. And one of the things Amy really wanted me to go through was a two-stage revision in that process, so we're going to try and go through that. There's two major criteria for infection. If they have two positive tissue cultures, then it's an infection. And I take three, so there's always a tiebreaker. One might be a contaminant, or if they have a sinus tract communicating with the joint. So if they have an open draining wound, that's an infection. And then we look for 3 of these 5 minor criteria. Do they have elevated CRP and ESRP, or ESR? Do they have a synovial white count that's elevated? And that can be, depending on what study you look at, it's kind of a objective study, or not a subjective study, where some studies would say it has to be, if it's 1,100, then that's positive. Some studies would say if it's 3,000, it's positive. So that one, there's not a hard number, which kind of makes it hard to evaluate that one. Elevated synovial fluid PMN percentage. So usually if it's over 65%, I consider that elevated. Positive histologic. So if you take tissue and I'll send it down to the lab during surgery, and they'll tell me how many white cells or infection cells versus inflammatory cells. And if that's positive, we use that as another one. And then a single positive culture. So if they're 2 out of those first 4, and then 1 positive culture comes back, then we're more likely to treat that one as a true infection, as opposed to if they're 0 out of the first 4 and then have 1 positive culture, then that's going to be more, to me, a contaminant. So every patient scheduled for revision gets ESR and CRP, and this is just an academy recommendation that if you're going to go to surgery, you need to make sure you rule out an infection. For the simple fact that you don't want to miss an infection. The other thing is, if they're positive, then I bring them back and I take fluid off the knee. And we look at that fluid and we send it to the lab. And the other thing that's not on this other slide is I send it for to another lab called Synovasure. It's a private lab that not everyone has in their hospital. But essentially, this is even a more sensitive and specific study to look for infection. And so if I'm kind of borderline on the fence for the minor criteria and it comes back positive or negative, I use that as my tiebreaker because it tends to be a little more reliable test. So they'll get aspirated, we'll send their fluid off. That's why I don't do aspirations on Friday or Thursday afternoon, because they don't pick it up then, and then there's a delay and you don't know how accurate that sample is going to be, and we don't have a place to store it here. So if someone's coming in for an aspiration of their joint, it's best not to schedule them for late on Thursday afternoon or on a Friday at all. So negative cultures don't particularly rule out an infection on an aspiration, because aspiration cultures aren't all that sensitive or specific or accurate for that matter. And so it's the tissues that I get during surgery that I look at are my most reliable cultures. Now if they're positive, then I use that, but a negative culture is not super helpful one way or the other. If I'm unsure or borderline, that's when I'll use the intraoperative frozen sections, but if they're pretty much 0 out of all the rest of the criteria, then I don't take extra tissue and look at it, because that is not as reliable, particularly in a community hospital. So I do that only if I need to. The other thing is about this taking tissue during surgery is then you're making a decision during surgery, and it's a little, you try and make sure that the patient knows what they're having before you go to surgery. So occasionally a patient will be scheduled for a antibiotic spacer versus a total joint revision based on the uncertainty of the first few criteria. So there's 2 types of spacers that I do for knees. For hips, it's all pretty much articulating spacers. I do static spacers and I do articulating spacers. The static spacers are pretty easy. Their rehab, as far as that goes, is we want to make sure they're getting up with a walker, they're stable. Everyone's going to be touchdown weight bearing. And this is kind of an example of a fellow that I really didn't trust too well. So a couple things. Do you trust the patient? What's their soft tissue envelope look like? If they have one of those draining sinus wounds or one of those wounds that just kind of burst open, they're probably going to need a lot of protection of that wound so that they can heal. This guy had good soft tissues, and this is the spacer that I've gone to, and it's worked out pretty well for me. I used to use cement on either side and make a lot of noise, and they'd be real stiff and they're hard to move. These are a lot easier. These ones have been doing a lot better for me. as far as this is a polyethylene, so this is a piece of plastic that you normally cement into the or put into the tibial base plate, and this is just a regular metal end, so that that's a much smoother articulating surface. The reason to do one or the other, again, this one is to protect the soft tissues or protect patients from themselves. This one is to, you can get a little more motion afterwards. The difference in the studies when you look at it is that with an articulating spacer, they get about 10 to 15 degrees more motion after their second surgery. So these guys, we will start doing range of motion. A lot of them end up in the nursing home, so we don't see them a lot in therapy. But at 2 weeks, if their wound looks good, I'll start moving it. And the goal is to get as much motion as we can before surgery, because that makes surgery easier and it makes their post-op rehab a lot easier as well. Hips, I just cemented a plastic liner with antibiotic cement, and I cemented just a regular implant here. We use a lot of antibiotics, 6 grams of vancomycin, 4.8 grams of tobramycin, and 3 grams of Ansef. The Ansef actually doesn't do much for treatment because it's not heat stable. The cement heats up whenever you're putting it in there, but it makes the cement more porous so that there's more surface area for these other 2 antibiotics to get out. Occasionally, patients, I have had one patient get some renal failure from all the vancomycin, but for the most part, those are pretty safe doses. You can see here, this guy had really bad soft tissues. He got himself a static spacer. So that's kind of what we're looking to see. Does it look like, do they have this horrible wound, or do they have much, like, does it look kind of like a normal total knee, but they just have an infection, an underlying. They're all going to be protected weight bearing, just because the cement that we use is not meant to be permanent, so we don't want the implants to dislocate or dislodge or anything like that, so I do protect the weight bearing. And again, the articulating spacers are going to start physical therapy at 2 weeks for a knee, for range of motion, hopefully. So for the 2-stage revisions, then as far as follow-up goes, they're going to be usually 2 weeks and 6 weeks is when they'll come to see me. And they'll be on their antibiotic regimen. They'll be seeing Dr. Sines like every week. She sees them all the time, and it depends on what our new ID doctor does. But they have enough appointments, you know, as long as their wound's okay, we try and limit their appointments. And then at the 6-week appointment, they should be about done with their antibiotics. And so once they're done with their antibiotics, then we put them on a 2-week antibiotic holiday and see how they respond. So I usually send them with lab work for 2 separate times at that appointment. Usually that day I like them to get their ESR and CRP checked, and then 2 weeks later we'll get the same thing checked. And we'll also schedule them for surgery that day for about a month out. And what that does is, if their ESR and CRP are going in a downward direction or staying stable, that means that they're probably safe off the antibiotics and the infection has been treated. If they go in the other direction, that means maybe we didn't treat the infection completely, and have them come in and we take an aspiration and we watch and we say, well, maybe we need to do a frozen section and see if we need to put another spacer in there. Or if it grows something out, then we know we have to do another spacer. And so, most of them will come in at their 6 weeks, they'll get their lab work all set up, they'll get their surgery all set up, and that'll be it for them until it's time for surgery. But some will have to come back in for an aspiration or something like that. And that's how that process goes. And the goal is to get it done in about 3 months for the patient, make it about a 3-month process. And if we're lucky, it can be, you know, around 10 weeks or so, a little bit shorter than 3 months. So ideally, for the revisions, we're going to treat them like a primary knee or primary knee replacement. We want to get their motion back, we want to get them going, but they're going to have, usually they're a little bit sicker, they're going to have longer surgery, a little bit longer incision, things like that. Sometimes they'll have more drainage, or they'll have had multiple surgeries. So I'll put them in a knee immobilizer for a couple weeks just to let the soft tissue envelope heal up, and then we'll start our physical therapy and range of motion after that. Sometimes they have more pain, and I've had a number of them that have less pain afterwards. It depends on what happens. Some people will get intraoperative fractures because the bone's a lot softer, or there's just less bone there to work with, and so they'll have a shell of bone that we have to kind of work with. And so that can also play into how much pain they have. The thing that I've noticed for my second stage of two-stage revisions, they tend to loosen up because they have so much scar tissue during surgery. They're nice and tight during surgery, and they loosen up over time. So a couple of those I've prescribed braces and things for. So those are some things to look at. And the only way to go back there and tighten them back up is to go back in and put a bigger piece of plastic in there or something like that. These are probably more likely to get transfusions. That's not something that's too much that you guys have to worry about. But in general, those are kind of some of the things that I'm thinking about at the time of surgery. How are these patients different? One thing we've done for the hip patients is we've started using the cell saver, which we collect their blood during surgery and we try and give as much of it back to them as we can. We can give up to about 30 to 40% of it back, which has helped, I think, with our transfusions. As far as the spacers go, some of the things to know is that the antibiotic spacers, they slowly elute that antibiotic over time, but after about 6 weeks or so, they're not really eluting much antibiotic anymore. What's actually more important is the debridement and then the systemic antibiotics that they get. We talked about the renal failure, more pain. Physical therapy goals are still going to be the same. We want to get them going fast. We want to get them up and going. In the hospital, I still have them work with them twice a day. I want them to get going. And even if they have an immobilizer on, we have to get them up with a wheelchair, things like that. So they might come in for physical therapy and have an immobilizer on where they're not being treated so much for their operative side, but they need to regain their mobility. Some of them have been maybe they've been wheelchair bound, they've been stuck in a hospital bed for a few days. Maybe, depending on how sick they were from an infection, they could have spent some time in the ICU. They just need some general rehabilitation as well. So those are things to think about. We talked about abduction limitations if I do an osteotomy. And most patients are going to be weight bearers tolerated, but occasionally they will limit their weight bearing depending on what their bone stock is or things like that. Another thing is started doing more revisions from the front now, and we just did one lady who we did her surgery from the front, but she's going to have hip precautions because she's an old posterior dislocator. So that's something that may come into play as well. She doesn't have good posterior tissues, as well as now we did the anterior approach. So those you might see that come across at some point. During the surgery, I do cultures on everybody. So while they're coming into the office, especially at their 2-week visit, we go through and we look at their cultures and we make sure that they're negative. They all start off on 1 week of oral antibiotics so that we can watch the cultures and make sure nothing comes back positive. Occasionally, they'll get out of the hospital, nothing will be positive, but then something will come back late. And those patients then may have to be set up with an infectious disease appointment or something like that. All the cultures are held for at least 2 weeks because Propionibacterium takes at least that long to grow out sometimes. We also check for fungal, which usually we don't get results for final results for 4 weeks, and acid fast can take up to 6 weeks to have a final culture result. That'd be things like Mycobacterium, tuberculosis, things like that. So I think expectations are important on these patients. What should our goal be? Patients, we want them to be home in their normal environment. I want them in outpatient therapy, so I want them to be coming here. I encourage them, because you guys work with most of our patients, to get them to get therapy here if they can. But we want them to really look at, especially revision hips and knees without infections and stuff, looked at as kind of like, that 3-month process. I want them back to their normal activities by 3 months. I try and get them out usually 1 to 2 days afterwards. I've been surprised at how many have been able to leave 1 day after surgery. My typical post-op regimen is pretty similar to during regular surgery, except occasionally I'll put them on more OxyContin. I'm more prone to put them on OxyContin for a few days, but that's not a chronic medication, maybe 4 days to a week max. And then I have them doing scheduled Tylenol, Oxy-IR, and then they get occasionally we'll add an anti-inflammatory in there. This is a one where this isn't a spacer. This is actually a total knee where we did not use a metal base plate. We used an all polyethylene tibia because this patient was allergic to metals. So this is a allergy sensitive or safe metal that one particular implant company makes, and then I try and get an all polyethylene tibia in there so that it doesn't have nickel. You see my dressings. Typically, the dressing put on in the OR is sterile. We put it in, put on a sterile environment, and as soon as that's gone, the sterile environment is gone. So we try and leave that on for 5 days. Occasionally they'll get saturated. These are the ones that drain. Occasionally these will be the ones who have the, they'll have an incisional wound vac on. And then that's where you might see them call in for an earlier appointment if you're scheduling appointments, and now they're scheduled for 2 weeks out, but they're coming in at 5 days. So these can be somewhat intimidating, so I usually have the patient come in and we'll take the wound vac off with them in the office. We'll look at the wound, make sure everything looks good, and then do some decision making from there. Occasionally they might be able to come out of their knee immobilizer faster. It may just be that they were just having more post-op drainage. I don't like to send them home with drainage because then they're doing dressing changes all the time at home. It just kind of becomes cumbersome. If they have the vac on, it's pretty easy for them as long as the vac doesn't get all clogged up. If they do call in with wound vac questions, one of the easiest things to do is tell them to turn it off and turn it back on. I had a lady call me over the weekend. Didn't have to do anything but have her turn it off and turn it back on. It stopped alarming and it was fine the rest of the weekend. If that doesn't work, then sometimes they may have to come in. One family didn't understand how to hook the things up, and as soon as they came in the office, it was clearly evident. So sometimes just getting them in so we can check on it makes it easier, as opposed to talking to them over the phone. So, the knee immobilizer, a lot of this is a little bit redundant. Another time we might use it for is if we have an at-risk extensor mechanism or extensor mechanism reconstruction, where we want to protect that for a long period of time. Wounds with drainage, wound vacs, and then at-risk patients. Something they just talked about already. In general, each one's going to be slightly different. It's not quite as cookie cutter as primary total hip or total knee replacement, but the principles are always going to be pretty much the same. And if you have questions, just triage us or come over and ask. It's typically a sicker subset of patients, especially for infections, and their immune systems are compromised for a reason a lot of times. When it comes to scheduling these patients, one thing I would ask is if you try and find out if they have a painful total joint, because it's not like a fracture or arthritis where it's just there on the x-ray. Okay, the x-ray is going to look the same a lot of times. Sometimes if they're grossly loose or something like that, it's easy to see, but it takes time to sit and talk to the patients, find out when they're having their pain. That's really important for stability. Instability, they're going to have pain when they're trying to get in and out of a chair, or walking up and down. When they're the problem with instability is they're using their collaterals and their other structures, such as their hamstrings. They get a lot of hamstring tenderness and they're tired. So it takes time to talk to them and figure that out. If they're trying to tell me about two different problems, it's hard to keep the patient focused if they're talking about both their knees or their hip and their knee. And then if we have to get into the other stuff in order to make the diagnosis, then we get into that. But if they have a painful total joint, unless they have bilateral knees replaced, it's best to schedule them just for that one problem at that time, because it takes the entire time for the scheduled appointment, and sometimes longer, in order to get it all straightened out. Whenever they call in a schedule, see if they can get their operative reports, because if we have to do a revision, it's good to know what kind of implants they have in, what size implants they have in. That makes it takes some of the questioning out during surgery at the hospital, allows them to maybe have less equipment there if we need to. Some vendors might have a hard time telling between the first or second generation of their implants, so they might have to have two whole different types of implants there if we don't have the operative report. And then find out if they've had lab work. If they're coming from another orthopedic doctor, they might have lab work, or if they're coming from their primary care doctor, they might have lab work. And so that can help us that can expedite the process. If they have lab work, then they don't have to send them out for lab work and then bring them back. So that might help them out a little bit. If they have images. So one of the things about loosening is it can be very subtle over time, And one x-ray isn't always very dependable on telling if it's loosening, but if you see a little black line that's kind of developing and it gets bigger over time, and they have x-rays from an old doctor that they were seeing, that can be very helpful for me in order to make the diagnosis on that visit, as opposed to having them come back 3 months later to take another x-ray to see what it looks like at that time. So those are all things that can be helpful whenever people are coming in for their appointments. I know it seems like a lot of work on their end, but it may save them a second appointment if they're able to get that stuff. And then as far as therapy, I do appreciate when you guys come in, let me know about wounds and things like that, because that's probably been the trickiest thing is wounds. They've had multiple surgeries, so they have a lot of scar tissue, and healing is definitely a bigger problem. So that's a lot of information, I know. What questions do you guys have?
I have one regarding the interrupter or the frozen sample. How do you, can you explain that again? And do you have a...
So I take tissue and then I send down to pathology, and instead of doing like a regular pathologic process, they freeze it quick and then they slice it up, put it on a slide, and they look at it and see how many like white blood cells, particularly the acute infection or inflammatory blood cells there are in the tissue, and if there's so many per high power field, then I know it's an infection or not.
So it's real quick.
Yeah.
It's done right then, and you.
So usually by the time I get done with my debridement,
okay,
they'll have 1 or 2 of the samples back, and so we'll, if we're kind of headed in the right direction, we'll start the reconstruction, or we'll start opening up the antibiotics or something like that.
I have another one about the metal allergy.
Yeah.
How do you know going in? Do you do certain tests beforehand to know if they're going to be
typically
allergic?
So if they tell me they're allergic, I use metal allergy. I treat it as a metal allergy usually, for a couple of reasons. One, they may or may not have a metal allergy, but if they think they do and they have any pain with that knee, they're unlikely to accept any answer other than the metal allergy, and rightfully so. I mean, because that's not what they were expecting. So yeah.
And is that one question that you ask, or is that one that is asked?
Usually, if I look on their, that'll be like on their thing, or
they have all that
they'll
on
say,
there.
yeah, well, I have allergy to cheap jewelry or something.
Okay,
like
so
that.
that's. Okay.
Yeah.
Or they'll tell me when they come schedule.
Yeah.
Well, I figured that you'll
okay.
hear it, but I wasn't sure when you catch that.
They call later saying, what is he using? And I'm allergic.
Okay.
To your knowledge, is there any other surgeons in this area that do the infectious revision?
I mean, you have to go to Akron, probably.
Okay. I just asked that. I kind of know the answer, but I get a lot of calling and scheduling. Wow, there's a lot of these being scheduled. Why is that all of a sudden? Well, so my understanding is before you came, there really was nobody in this area that did something like this. Is that?
Yeah.
Would you say that's exact?
Out to.
And then they were just shipped up to
Right. Canton or
somewhere else.
Akron or.
And so now that you're here, that's why we see more and more.
Yep.
I just wanted to.
Your osteotomy, how do you do that? You see the loops on there?
Yeah, so it's kind of like
It looks like zip ties.
I take a little saw, and I'll usually I'm looking at one side or the other. So if my approach is from the front, I can see the front of the bone, and I can see laterally from the side. And then you get it a little bit in the front if you're going from the back, or if you can see a little bit in the back when you're going from the front. So basically, you start it, and you saw the side that you can see, and then you make the lateral cut, and then you use some osteotomes, and you just open it up like a door. And if you've done some way to start it on the back side or the front, the side that you're not on, it'll typically just kind of crack how you want it to.
Okay.
And then I'll put a cable down below so that it doesn't crack down the rest of the shaft before I start trying to make my crack.
So the cables that are look like loops
So
the whole way down?
yeah, those are just fixing everything. They're kind of tying the sandwich back together.
Okay.
But there'll be one cable usually right below where the bottom of the osteotomy was.
Okay.
And that's usually to protect a couple things. One, from from it fracturing down the shaft when I go ahead and try and make the osteotomy. And two, whenever I'm reaming, in order to make room for this